Welcome, and thank you for joining us today. At the Center for Trauma and Resilience Research, we believe that healing and growth are both deeply personal and profoundly communal. Whether you are a clinician, educator, advocate, student, policymaker, or someone seeking to better understand the effects of trauma, your presence here matters. This presentation is an opportunity to explore how cutting-edge research, compassionate care, and lived experience come together to advance mental health, emotional resilience, and social change. We know that trauma touches every community, but so does the power of resilience. Our mission is rooted in a simple yet powerful idea that recovery is possible and knowledge can be a pathway to hope. Through science, storytelling, and systemic innovation, we aim to foster spaces that are safe, inclusive, and transformative. We're honored to have you with us as we share, learn, and imagine a future where resilience is nurtured. Trauma is addressed with dignity, and every person has the opportunity to thrive. Welcome. We're so glad you're here.
Welcome, everyone. Today's presentation is titled About Apathy. We'll explore the complex and often misunderstood syndrome of apathy, its clinical features, neurobiology, treatment options, and social implications. Whether you work in mental health, neurology, public health, or education, this talk aims to deepen your understanding of apathy and its wide-ranging impact. Apathy is not simply laziness or disinterest. It's a clinical syndrome marked by a significant reduction in goal-directed behavior, thought, and emotion compared to a person's previous baseline. This means people may stop initiating activities, seem emotionally flat, or withdraw socially, not because they don't care, but because something neurologically or psychologically is impairing their drive. Apathy presents along three primary dimensions: cognitive, poor planning, lack of interest, emotional, blunted affect, and behavioral, decreased activity. Diagnostic frameworks, like the Apathy Diagnostic Criteria, Miller et al., 2021, help clinicians assess these traits. Tools like the Apathy Evaluation Scale, AES, or Dimensional Apathy Scale, DAS, are widely used. Many factors contribute to apathy. Neurodegenerative disease is the most common cause, but cerebrovascular injury, social isolation, and medication side effects, especially with SSRIs and antipsychotics, also play a role. Cultural and environmental elements, including disconnection from purpose or role loss, may amplify these effects. Padala et al., 2020. Dolnina, 2020. The neurocircuitry of apathy primarily involves the anterior cingulate cortex, orbitofrontal cortex, and the nucleus accumbens. These brain regions are responsible for evaluating effort and reward, decision-making, and motivation. Dysfunction here can disrupt a person's ability to care, decide, or act, often regardless of emotional desire. Morris et al., 2023, Mehak et al., 2023. Clinicians must distinguish apathy from depression. While they overlap in reduced motivation, depression includes sadness, guilt, and pessimism, emotions not typically present in apathy. In apathy, there is an emotional neutrality rather than despair. This distinction is vital because treatments for depression, like SSRIs, can actually worsen apathy in some cases. Langta et al., 2023. To accurately identify and measure apathy, especially in clinical and research settings, we need reliable assessment tools. One widely used measure is the Apathy Evaluation Scale, which evaluates behavioral, emotional, and cognitive aspects of apathy based on self-report, clinician input, or informant observations. Another valuable tool is the Neuropsychiatric Inventory Apathy Subscale, often used in dementia settings to assess the severity and frequency of apathy symptoms. Additionally, structured diagnostic criteria, such as those proposed by Miller et al. Apathy affects not just the individual, but their entire support network. It is linked to reduced independence, lower participation in therapy, earlier institutionalization, and higher caregiver burden. Post-stroke apathy is associated with worse rehabilitation outcomes, and in dementia, it correlates with more rapid cognitive decline. Paluca et al., 2024, Sankey et al., 2025. Philosophers have long debated the value of emotional detachment. The Stoic tradition, for instance, saw apatheia as a path to virtue. But clinical apathy lacks intentionality. It's not chosen, it's suffered. When disengagement strips away purpose and empathy, it poses ethical concerns about personhood and social responsibility. Ponthier, 2023, Stoliarov, 2023. Non-medication treatments offer hope. Cognitive behavioral therapy, personalized goal setting, and motivational interviewing can help re-engage individuals. Technological tools like reminder systems and social robotics also show potential in boosting engagement. These approaches are adaptable, cost-effective, and avoid the side effects of medication. Maneret et al., 2020. There is no FDA-approved medication for apathy, but some pharmacological strategies have shown promise. Methylphenidate is being investigated for Alzheimer's-related apathy. Other drugs like dopaminergic agents and modafinil may offer modest benefits. Still, apathy is often treatment-resistant and pharmacologic results remain mixed. Langtut, 2023, Nagy et al., 2025. Apathy isn't limited to the clinical setting. Studies reveal growing political and civic apathy, particularly among younger generations. Factors like disillusionment, perceived lack of agency, and media saturation may contribute. Understanding apathy on this scale is essential for sustaining civic engagement and collective action. Noredin and Rudra, 2025, Jelnina, 2020. Research must now focus on refining diagnostic tools, developing effective treatments, and integrating genetic, psychological, and societal perspectives. Interdisciplinary collaboration will be key, uniting neuroscience, geriatric psychiatry, philosophy, and behavioral economics. Only through this integrative approach can we fully address the scope of apathy. To conclude, apathy is a multifaceted, pervasive issue with deep clinical and social consequences. Better awareness, earlier diagnosis, and broader societal interventions are needed to counter its impact. Thank you for your attention.
Thank you for being part of today's journey. Your time, attention, and openness reflect a shared commitment to understanding trauma and championing resilience, not just as clinical or academic concepts, but as lived realities that impact our families, communities, and futures. At the Center for Trauma and Resilience Research, we believe real change happens when knowledge meets compassion and when diverse voices come together to drive healing forward. Whether you're here to learn, advocate, collaborate, or reflect, your presence matters, and your efforts make a difference. As we close, we invite you to stay connected, continue the conversation, and carry forward what you've learned into the spaces where you live and lead. Healing is not linear, and resilience is not one size fits all. But together, we can build systems, relationships, and responses that support recovery, dignity, and hope. Thank you again for joining us. We look forward to walking this path with you. These are the key sources that inform this presentation. They represent research from psychology, theology, and cultural studies.